the oblique and transverse head. Pull the hallux laterally, and you end up with hallux abductovalgus, crowding the lesser toes, overlapping toes. They walk into your office like this. The first thing you're going to do is you're going to want to measure the intermetatarsal angle. So you're going to take an x-ray, bisect the bones. Why? Because it tells you what surgery to do. I'm going to ask an interesting question. How would you reverse a bunion without surgery? To the degree that you're still flexible, if you could take the first metatarsal and move it back down and in on its axis by raising the longitudinal arch, you could actually reverse some part of the bunion, the flexible component of that bunion. Does that mean you'll never do bunion surgery? No. But it does mean that some bunions can be treated conservatively. Stress fracture. Stress fracture is a matter of distribution of forces along the ball of the foot. If the first metatarsal takes a vacation, not bearing its share of the weight, it's 60%, the weight's transferred to the lesser metatarsals and they break. And you end up with a stress fracture. How could you prevent recurring stress fractures? Change the force distribution on the ball of the foot. Raising the longitudinal arch transfers force to the first metatarsal head at toe off. We did a study at Georgia State University. It was published in 2006 in the Clinical Journal of Sports Medicine, where they showed by raising the longitudinal arch compared to standard orthoses that use posting, out of the box, 44% more force is transferred to the first metatarsal head. At 6 weeks, 61%. And that was comparing raising the longitudinal arch to the best orthoses they had ever tested out of 20 different labs that they tested. Metatarsalgia. There's a bursal sac underneath each metatarsal. When the first one takes a vacation, the bursal sacs get inflamed. We get bursitis. So we inject cortisone. What is that? It's the great see-no-evil. Let's cover the pain while the patient continues doing the damage. What if we transfer the force back onto the first met, which is designed to handle it, making it bear its share of the weight, transferring the weight off the lesser metatarsals, and the pain goes away. Mortons neuroma is caused by the transverse metatarsal ligament. Body weight comes over an unlocked foot. The first and fifth metatarsals, they begin to splay, tightening the transverse ligament, transferring more force onto the lesser metatarsals because they're going up and out to the side. The nerves in the first and fourth interspace are offloaded, and the nerves in the second and third interspace increase their force. So the Schwann cell around the nerve enlarges to protect the nerve, creating a benign tumor, a swelling of the nerve. We call it Mortons neuroma. It's a reactive lesion to excessive stress. But as you walk, you drag that tumor forward with all the other soft tissues, and it ends up between the base of the phalanges where it's intermittently squeezed. So the first sign is nerve compression, burning. Then interruption of signal, tingling. Then no signal, numbness. Then sharp shooting electrical pains. They walk into your office, you see the space, you go, let's trade pain for numbness. I'm going to take out the nerve. And I say you're going to be permanently numb between the toes in an area the size of a quarter on the ball of the foot, right? No, axons grow back a quarter of an inch a year. They grow back under the newly scarred, thickened transverse ligament. Before they even get to the interspace, they're forming a brand new stump neuroma. And you have to go in and treat them again. Wouldn't it be better to supinate the foot, bring the first and fifth down and in on their axes, release the stress on the transverse ligament, make the first and fifth purchase the ground, which would mean less stress on 2, 3, and 4. The human body is in a constant state of replacing itself. You replace your thin skin every month, your thick skin, palms and soles every 3 months. You replace your nerve sheaths and they grow back normal. 6 months later, they've remodeled, the toes have come back together, and you could squeeze all day long and no pain. In other words, Mortons neuroma is a reactive lesion. Remove the force that's causing it, and the human body will heal itself. As the foot flattens, it elongates. It pulls on the flexor and extensor tendons, especially the extensor hood, causing the toes to hammer up. Form follows function. I never understood that until I went to a lecture by Dr. Green on hammer toes. And he's up at the podium going, form follows function. And I couldn't wait to pull him in the hallway. I said, Don, what does that mean? And he said, Ed, it means if you walk around like this, you're going to be like this. And I said, oh, stupid-nagel. That makes sense. Everything we treat starts out flexible and becomes rigid over time. As surgeons, I used to like to wait till it was rigid, because then it rubs the shoe, and they get a corn or an ulcer, and they're willing to go under the knife. But the fact is, the vast majority of hammer toes that walk into your office are still flexible. That's why they haven't formed a corn. That's the time to treat them. Why? Because when you raise the longitudinal arch, you shorten the distance from heel to toe, release the pull on the extensor tendon, and the toes straighten out over time. By reversing the forces, you can actually reverse the deformity. Tailors bunion. Metatarsal splay. Theorem 7. Fifth metatarsal goes up and out laterally. How is supinating the foot going to reduce Tailors bunion? Remember, there are two columns to the foot. Medial column, those bones coming off the talus, and lateral column. As you supinate, you externally rotate the talus on the calcaneus, which means you're moving the medial column over the lateral column, which brings the fifth down and in on its axis. It's the reverse of Theorem 7. If Theorem 7 is correct, compensation causes splay. Reversing compensation would bring it back. Peroneus longus tendonitis. Peroneus longus, as you know, comes down the lateral side, makes a sharp turn at the cuboid notch, and attaches to the base of the first metatarsal. When you pronate, the peroneus longus is nothing but an isometric stabilizer of the first metatarsal. What does that mean? It means the same section of tendon is pulled tightly around a 90-degree turn all the time. You end up with peroneal tendonitis. Supinate the foot, and what happens? You shorten the distance between the insertion and the notch, make it come down at an angle, and becomes an active plantar flexor of the first metatarsal. And now you have a smoothly moving tendon around the cuboid notch, and you've eliminated peroneal tendonitis. Tibialis posterior tendonitis. The tibialis posterior comes down the medial side. Did you ever notice the tibialis posterior, the tibialis anterior, and the peroneus longus all come together at the medial longitudinal arch to act as a triple sling to hold the arch up? Tibialis posterior has the best mechanical advantage to support the arch, to pull it up. So what happens as the foot collapses? It's pulled beyond its anatomical range of motion and literally shuts off. We used to call it PTTD, posterior tibial tendon dysfunction. Now it's called something I don't like, adult acquired flat foot, which doesn't really describe what's happening. You want the tibialis posterior tendon to turn back on, the muscle to turn on? Put it back in its anatomical range by putting the foot into greater supination. You're starting to notice a pattern? Supinating the foot ends up making it more functional. Meanwhile, the tibialis anterior. We think of the spring ligament as your shock absorber. How does shock absorption work? By reaching the end of pronation, the talar head lands on the spring ligament to slow down the forward roll and act as your shock absorber. But when you overpronate, therefore, which muscle is going to suffer the worst? The one with the longest lever arm. It's going to be pulled so far beyond its anatomical range, it will actually rip. Where does it rip? It rips at its weakest point, the thin interosseous membrane between tibia and fibula. Tiny tears and hemorrhage, inflammation in the membrane, are what we call shin splints. Want to get rid of shin splints? Put the foot into greater supination, so you're not allowing the tendon to go so far that it has to tear.